Hello everyone and welcome. My name is Fernando Florido and I'm a GP in the United Kingdom. With today's episode, I'm starting a new series on diabetes guidelines in practice, looking at how the guidelines could apply to randomly selected clinical cases. By way of disclaimer, remember that guidelines are there to be interpreted and applied using your clinical judgment. I am not giving medical advice here, and what I'm only doing is sharing with you what my interpretation of the guideline would be in this particular case. It does not mean that it is the only way or indeed the best way to treat any individual patient, so you must always apply your clinical judgment at all times. I will also say that I will only focus on the pharmacological treatment of type 2 diabetes. By all means, we will need to advise about diet, exercise, lifestyle, etc., but this will not be addressed in these episodes. Remember, there's also a YouTube version of these episodes, so have a look in the episode description. Right, so let's get started and let's generate a random patient. For that, I have used a random spinning wheel to choose the demographics, the HbA1c level, eGFR level, number of diabetic drugs, medical history and BMI. And the outcome of this randomization was that we have an 85-year-old man, newly diagnosed with type 2 diabetes, who is poorly controlled, with an HbA1c of 65 mmol, or 8.1%, who also has heart failure and CKD stage 3B with an eGFR of 32. In addition, he's also underweight, even possibly malnourished to some degree, with a BMI of 17. Right, we're going to look at the guidelines and how to apply them. Although I will focus on the NICE guideline, in this case my interpretation and the outcome would be exactly the same if you follow the European Association for the Study of Diabetes recommendations or the American Diabetes Association guideline. So what does NICE say that we should do? Firstly, we need to consider if rescue therapy is necessary because for symptomatic hyperglycemia, we will need to consider insulin or sulfonylurea and then review when blood glucose control has been achieved. So we're going to assume that this patient is well and he has no symptoms of diabetes. He is underweight, but this has been like this for a few years. There hasn't been rapid weight loss indicating an urgent need for insulin, and his urinary ketones are negative. Other causes of unintentional weight loss, such as cancer, have also been excluded. So we're just focusing on the diabetes. His HbA1c is high and has not improved with diet and lifestyle advice, so we should do something. However, given his age, we're not going to manage him too aggressively because at 85, we're probably more concerned about harmful hypoglycemia. But he does need treatment, and certain diabetic agents could also help his comorbidities. So next, we must look at his medical history. He has both CKD and heart failure, and we know that SGLT2 inhibitors can be beneficial for both these conditions. However, because of the benefits of metformin, NICE says that first we should consider starting metformin alone to assess tolerability, and once this has been confirmed, we should add an SGLT2 inhibitor. Arguments against using metformin at all for this patient are that his eGFR is fairly low, and at 32 he is quite close to CKD stage 4. Also, because he's underweight with possible low muscle mass, we need to remember how the estimated GFR is calculated and consider that as a result of the low muscle mass, his eGFR may be overestimated and that his actual GFR could be below 30. We know that we can use metformin quite normally if the eGFR is above 45. We need to review the dose and prescribe it cautiously if the eGFR is between 30 and 45, and then stop it completely when the eGFR falls below 30. The manufacturer of metformin also advises caution in chronic stable heart failure, with the advice to monitor cardiac function closely. We also know that metformin can have potential gastrointestinal side effects and promote weight loss, which would not want in this patient. And finally, the mode of action of metformin is primarily by reducing insulin resistance. But in an 85-year-old underweight patient, it is more likely that his diabetes is due to insufficient insulin secretion by the aging pancreas. On the other hand, we also know that metformin has proved to have cardiovascular benefits. So a controversial decision, you could justify both giving and not giving metformin based on this patient's individual circumstances. Right, time to decide. What would I do? I would probably err on the side of caution and not give metformin. It can always be introduced later if his weight goes up and his renal and heart failures are stable or improve with other medication. If you really wanted to prescribe metformin, it would be best to start a very cautious introduction, maybe 500 milligrams daily, and then monitoring the patient very closely. Generally, the maximum accepted dose of metformin for patients with an eGFR between 30 and 45 is 500 milligrams twice daily. But I would be quite nervous about it, and I would not increase the dose above 500 milligrams daily for this particular patient unless the circumstances really changed. But we're not giving metformin, but we will need to prescribe something for this patient. And NICE says that if there's a history of heart failure, we should give an SGLT2 inhibitor with proven cardiovascular benefit. NICE says that the benefits in reduction of hospitalizations for heart failure and cardiovascular mortality can be attributed to SGLT2 inhibitors as a drug class, although at present ertugliflozin has not consistently shown these cardiovascular benefits in clinical trials. So we're likely to choose either dapagliflozin, canagliflozin, or empagliflozin for this patient. Remember that SGLT2 inhibitors are also associated with possible weight loss, so along with this prescription, there should be appropriate nutritional advice. We also know that there may be an increased risk of diabetes ketoacidosis, or DKA, associated with the SGLT2 inhibitors. So NICE advises us that before prescribing, we should check the patient's individual risk of DKA, for example, if they have had a previous episode of DKA, or they're following a very low carbohydrate or ketogenic diet. In particular, I would be very keen to make sure that this patient does not continue to lose weight, as this is also likely to put him at greater risk of DKA once the SGLT2 inhibitor is started. Also remember that we will need to check our formulary, or PNF if you're in the UK, because each drug has its own recommendations and eGFR thresholds for dose reduction, caution, or avoid. Acceptable options would be dapagliflozin, maybe starting cautiously at 5 milligrams daily, possibly increasing to 10 milligrams daily if no issues develop. Canagliflozin, starting at 100 milligrams daily, which is the starting dose and also the maximum daily dose for anyone with an eGFR less than 60. Or empagliflozin, starting at 10 milligrams daily, which is also the starting dose and the maximum dose for anyone with an eGFR less than 60. So that would probably be my first pharmacological action for this patient, but by no means necessarily the only or the best one. Remember that we need to keep monitoring the patient and consider other treatments as and when the situation changes. We have come to the end of this episode. I hope that you have found it useful. Thank you for listening, and goodbye.